the next session is going to be around innovation, something close to my heart. And we've just heard considerable skepticism about the resources that are available to deliver the agenda that we're talking about at the moment. And a lot relies on both new technologies and new diagnostics to innovate and to look at how we can reduce that burden. And I'm pleased that we now are going to introduce both Geraint Lewis and Professor Zoe Kourtzi to talk about these areas, and then we'll move on to sort of the challenge to it and what the challenge is for dementia in terms of using some of the new technologies. Geraint, could I start with you first and just introduce yourself, and then we'll come to you 2 minutes after we've talked briefly to Zoe.
So, good morning, everyone. Nice to see you again, Mike. Geraint Lewis here. I'm the Director of Population Health at Microsoft. I'm a public health doctor by trade, and I have a specialist interest in population health. As a public health registrar, I'm actually the person that invented virtual wards, which have now sort of gone viral across the NHS 15 years later. But more recently in my career, I was the Chief Data Officer of NHS England for 9 years.
Thanks, Geraint. And Zoe.
Hi, thanks, Mike. Good morning. So I'm Zoe Kourtzi. I'm a professor of cognitive computational neuroscience at the University of Cambridge. And I also have another hat. I'm a fellow at the Alan Turing Institute, the UK's National Institute for AI and Data Science. I work in the space of early dementia detection and prediction, building AI models that are transparent and interoperable and allow us to make these early predictions really interesting to hear the discussion in the previous session. So my work is at the interface of neuroscience and computer science. Yeah, I look forward to your questions.
Thank you very much, Zoe. Geraint, good to see you again as well. And please give your 2 minutes.
Thank you. For my 2 minutes, I wanted to talk about opportunity and caution. Starting with opportunity, this audience doesn't need to hear this, but we all know that dementia places an enormous and growing burden on society that disproportionately affects many disadvantaged groups. There is an enormous potential. We know that there is a clinically silent phase to dementia that can last up to 20 years. And some studies suggest that tackling things like obesity and hypertension during that phase can lead to a 40% reduction in the incidence of diabetes. I'm quite excited, as probably you can imagine, working in Microsoft by the technology, and some of the technology that's coming out in relation to making a diagnosis, I think, is particularly exciting. The way that it is less subjective than traditional ways of making diagnoses, that it can be more accurate, that it certainly can be more efficient. We were talking in the previous session about making diagnoses in kind of community centres. I think technology has the potential to bring that even closer to home with the use of smart environments and detector devices. Then when it moving on to the kind of the treatment side of things, I mentioned virtual wards, that whole concept of doing things that traditionally would have needed a hospital admission. So maybe a dementia patient with concurrent pneumonia, for example, maybe be able to treat those at homes. And then finally, thinking about the data, the opportunities to analyze data, to detect gaps in care, to see which patients are not receiving the preventive care that they should be, or indeed the treatments for dementia. So lots of things to be excited about. On the caution side, though, I would really like to underline what Sebastian was saying earlier about the hazards of sort of slipping into thinking about potentially screening or making early diagnosis. I think it's really important for us all to note that NICE explicitly disapproves of case finding for dementia outside the context of clinical trials that specifically offer early treatment. So we need to be really careful about that. And the reason, of course, is that as these tools become more prevalent, so the use of smart devices and so on, we need to remember that they will never be 100% accurate. Yes, artificial intelligence has the potential to massively increase accuracy, but they're never going to be 100% accurate. And so there will always be false positive and false negative results that we need to be very mindful of. The good news is that the World Health Organization thought about this back in the 1960s. So there's a set of criteria called the Wilson and Jungner criteria that I would commend you to look at if you haven't come across them. And likewise, with the use of AI itself, one of the things that my employer, Microsoft, is very, very cautious about. So we have something called the Responsible AI Framework, which I think we should be applying to any potential new use of AI. And that Responsible AI Framework covers a range of factors, including fairness, reliability, privacy and security, inclusiveness, transparency, and accountability. So in summary, I think technology and AI in particular has mind-blowing potential to transform how we manage and prevent dementia, but there are always these potential unintended consequences that we should be very, very careful about.
Thank you, Geraint. And I totally agree. You know, the sort of specificity angle of this is rarely ever talked about in terms of accuracy, and your false positives are going to have major difficulties. Zoe, can we come to you now and your introductory?
Yeah, certainly. Thank you. Yeah, just to pick up on the point, definitely, appreciate the challenges with AI. I'd like to talk to you a little bit about the potential that it has to offer, and maybe just a use case from the research we've been doing. So we're very much interested in exploiting this kind of AI revolution for early prediction and detection of neurodegenerative diseases, and in particular dementia. Thank you for sharing the slides. If you want, you can keep going as I talk. The challenges really that we have is that the models that we build have to be clinically relevant. They have to be biologically informed, and that is really important so that we can make predictions that really generalize. They're not just specific and biased to specific populations, for example. Then it's really important that these models are interpretable. We can understand why, what are the factors that drive the model's decision when it makes a prediction about dementia. And that brings us very much into reducing misdiagnostics, these false positives and negatives. And finally, we recognize dementia really a global problem, and therefore we need these models to provide global solutions, and they need to be interoperable. There is no good in creating a model that is specific, let's say, to the UK. We have in our hands a global challenge. And if you'd like to see the slides, we're now in slide 4. So our work focuses in early detection and prediction, and really interesting conversation earlier on about prevention. Now, why do we do this? This is because we know that dementia, the causes of dementia start in the brain 10 to 15 years before symptoms occur. Now we have a huge window there to really work on brain health checks, to really work on cognitive prevention. And that's really important because if we can intervene, for example, by changing lifestyle factors, we could have cases where dementia actually never occurs. The next reason why this early kind of detection is really important is because we can change the clinical pathway. We can change the diagnostic pathway that patients have to undergo, which currently is quite invasive. It's quite costly for the NHS, and it generates more anxiety to the patients and their carers and their families. And we can also put more personalized treatment plans in place, which now are becoming more imperative given the potential that we see in new treatments. So if we move into the next slide, that's just to give you an idea. These models are very rich, although we built them to be very transparent based on the responsible AI framework that Geraint was describing. Their beauty is really they get to see thousands and thousands of cases, like a really advanced clinician would have seen many cases throughout their life. These models get to see thousands examples of patients from across the world and pull out not only single data, but multimodal data, very different types of data. And that's really where their power comes from. And we heard about, for example, amyloid not being really predictive. What do we do with people that have amyloid in their brain, but actually do not have dementia? They don't have pathology, they won't express the disease. And that's what you can see in the next slide, is that these models can really help us reduce misdiagnosis. This is applying really the models to patient data. This is a pilot study that we have ongoing in several memory clinics currently in the UK. This is real world patient data. And what you see is the models can really help us discriminate at the bottom there where it says cognitive normal, who are the people that will remain stable throughout time, and who are the people actually that might move slowly or rapidly. And then the next slide, you can see that this way we can change the pathway, the diagnostic pathway. People that remain stable can go back in the community with no particular concern. People that are rapidly progressive are the people that will need to be putting into the experimental treatments, putting all our resource against them while we are saving resource for the people that will be stable. People that are slowly progressive, potentially we can put more social care around them and more follow-ups. And so finally, just to say that we are looking with great hope and caution to this revolution of AI and technology to be able to support clinicians, not to replace clinicians, but to support them through the space of technology to assign the right patients at the right time, at the right diagnostic and treatment pathway, to improve the patient well-being while reducing costs for the NHS and improving the quality of diagnostic and treatment care for the patients. But also we are hoping to support drug discovery, which currently has been really difficult because of the heterogeneity of patients with dementia. So we see examples of drugs that have the potential actually to work if the stratification through this modeling effort can be more precise. So I'll stop here and really looking forward to your questions.
Thank you very much. So yeah, you do make the very well the case for accurate diagnosis and giving the people the right prognosis, as opposed to a sort of a mismatch that I think we're all experiencing at the moment. I'm going to hand over to Jill in a second to talk around the technology questions. And Jill, I'll give you a sort of broad brief to delve into all of those questions that we've sort of listed. But I think this session, if anything, will help us not only deliver the sort of knowledge around the excitement of innovation, but also its limitations in delivery at the moment, and expectations that are raised in the press are often around treatments, but also around diagnosis. And I think it's important that we have a balance at the end of this debate. Jill, I'll go on to you there.
Thanks, that was really interesting. Lots I could pick up on, but I just want to think about the use of AI in pre-diagnosis, if you like, that bit about alerting people to the fact that they might have dementia. I mean, my mother had dementia, and it was only when she could no longer follow a recipe that I realized there was a problem, and I wish I'd realized earlier. So my question is a practical one. How might this work in practice? Is it going to actually be something that individuals decide to enable so that they get an alert on their phone that says, hey, you aren't performing as well as you used to? Or is there ever likely to be an NHS-wide solution around technology to do this, knowing that that's often a challenge to implement technology across the board? But if we leave it to individuals, is that just going to increase inequalities? So I don't know who'd like to answer that first. Perhaps Geraint.
I'll have a go. Yeah, I do want to underline my kind of health warning earlier, and as you know, NICE explicitly disapproves of what we're talking about at the moment. So other than in the context of a research study, so please do remember that. So
As I can put my nice hat back on. Of course, things do get revisited in the light of new evidence. So I'm trying to sort of, forward plan.
The reason I underline it is because I do worry, there are tech companies out there that are doing all sorts of really exciting things, and as policymakers and clinicians, we're sometimes attracted to the shiny new toys, and I think the importance of kind of research governance wrapping around it is critically important. So I know I'm banging on about this, but I do genuinely think it's important. To answer your question, so yeah, there are all sorts of ways that you could do it. It's quite remarkable. Using AI on some of the data feeds that we get from our devices and what you can now do with them. So there are companies out there developing, for example, tools that can measure all sorts of vital signs just using a small snippet of selfie video. So you can record blood pressure, oxygen saturation, pulse, even fever, just using the camera on your phone, which sounded like something kind of from science fiction even a few years ago, but they're inching towards getting full medical device approval for it. I was speaking to somebody the other day who uses a device that will listen to 3 footsteps and can pick up all sorts of diagnoses and work out if you're at higher risk of fall. So I think, yes, a combination of devices that we might wear on us, things that we keep in our pocket, so our phone, and then the increasing prevalence of devices like Alexa and Google Home that can pick these things up. Will it ever be an NHS? I mean, yeah, so I think your point is very well made about the potential for inequalities, both in terms of what's called the inverse care law, so the people that most need access to high quality care finding the most difficulty to access it. And we see the same thing with devices, so higher prevalence of devices in people with higher incomes and with the more modern devices and so on. But also, if it is something that you actively need to switch on, there's another phenomenon called the inverse equity hypothesis, which says that the people that are most likely to benefit from making that active choice to switch on are the least likely to do so. So Sure Start centres being the kind of classic example of that. On the other hand, do I see it? I mean, you could imagine a world where it might be incorporated into the NHS app. You could imagine a world where you needed to opt out of it. But I think the main point I would make is to think through the ethics of it and the clinical governance, and crucially to involve information governance right from the start. I had the joy of managing NHS England's information governance team for the best part of a decade, and they get a very bad rap from people, but actually if you bring them in early, if you treat them with respect and you treat them as if they're members of your multidisciplinary team, then they can really help facilitate this kind of innovation.
Thanks, great answer. Have we got time to also have a
reflection? Yeah, please, yeah.
Zoe.
Yeah, thank you. Yeah, so just yeah, I completely agree with all this. Just to bring another kind of point in this discussion is it depends whether we want really precise diagnosis or just warning signs. So as Geraint was saying, there's lots of apps out there. There's lots of people that are looking at different signs from different modalities, and wearable technologies have great potential. But actually, you know, you could get the flu and start slowing down a bit, and maybe you have long COVID, and these kind of effects kind of last longer. You have some inflammation, some infection. So warning signs, I think, that can be compounded, let's say, by kind of aging, could look like they're giving you that picture of symptoms of neurodegenerative disorders, but maybe actually, again, you're not going to express the disease. So that's where potentially, you know, what could happen at home is some kind of assessment, earlier assessment of warning signs, very early on in that window of 10 to 15 years, potentially, before key symptoms start to appear. But then I think it will be really important that that gets integrated in some kind of prevention workup in the NHS, where the models actually that look at this are not just built on this wearable data, but they are built also on a lot of existing data. For example, data that look into the pathology, MRI scans, PET scans. And the beauty of the methods that are currently being developed is that these kind of large foundation models that allow us to integrate both biological data and wearable tech can be built to be robust and reliable and interpretable, but then they don't require the more invasive data. So from new patients, potentially we can give these models only wearable data and make reliable predictions for their trajectory. So there's great potential, I think, going then into NHS, where we can have the right governance for AI models to give us more precise answers in a way. And then we will be able to make a more clear prediction about individuals that can look also into different dementia subtypes, which is really important for the diagnostic pathway. This way, I think we cut a lot also kind of inequalities, but also a very invasive diagnostic pathway that is very costly and very kind of, you know, overburdening for patients and their families.
Thank you both. Jill, we'll move on there if you don't mind. I think what I picked up from that was, and going back to Geraint, you were mentioning Wilson and the postulates around, if we're going to have early diagnosis, we have to be able to do something with it. We have to have and there has to be equity within the system as well. The fact that we can do things doesn't mean we should do things, I guess. We're going to move on to the sort of personalized intervention side of this now. Corinna, can I just ask you to lead on the questions there, please?
Yeah, so I think, taking into account what Geraint said about, shiny new toys, and as policymakers and clinicians, it's easy to get distracted by these shiny new toys. But I think if we're sort of thinking about this sort of general shift to personalized medicines, how can we use these kind of tools to really personalize that care? And how could that in itself help overcome some of the inequalities we've talked about earlier and in this session? So Zoe, can I come to you first and then Geraint?
Yeah, sure. Yeah, again, I think there's great potential in that. So we've heard a lot about what we call comorbidities, other potential disorders and health issues that individuals have as they age that can impact their cognitive abilities and bring along kind of symptoms that give that picture of dementia. And I think that's where personalized care can make a big difference. The interesting example that I think Sebastian might have been referring to is that we see in certain regions, for example, where preventative care for cardiovascular disease has been put in place, we see reduction of dementia. If we can do this in a personalized way at home, if we can look after hearing loss potentially and cardiovascular disease, we might have great benefits in changing this pathway that will bring along symptoms for dementia. So again, kind of going back to the technology, if when the first warning signs are seen at home, then an individual can go to their GP and kind of have a full workup about other types of conditions that might impact dementia, like cardiovascular disease and like hearing loss, for example. It could make a big difference in preventing dementia.
So I'd like to answer the question in two parts, one to do with data and one to do with technology, if that's okay. So on the data side, I think if you read through the nice kind of guidelines for dementia, they are pages and pages long, very, very detailed, very precise. But if you're a busy GP or a carer, trying to navigate your way through them can be time consuming and challenging. So I think there is a growing role for technology in helping to make sure that that guideline is being followed. So making sure that all of the basics are being done correctly, making sure that the dementia treatments are correct. So if somebody should be on a second line treatment and they're not yet, or if they've jumped to a second line treatment without trying out the first line treatment, being able to pick those things up is really important. It's what's known as in the trade as detecting gaps in care, which is it's defined as a deviation in the data that's been recorded about a patient, a deviation between that and the care that you would expect a patient to have received had evidence-based guidelines been followed to the letter. And there's a relatively new phenomenon called next best action, which helps simplify that right down. So if you're going to do one thing, if you had a magic wand to sort of improve a patient's care, what would that one thing be? And that would differ. For some people, it might be treating their diabetes more carefully. For other people, it might be for reducing their blood pressure. So gaps in care, I think, is one side on the data front. And then on the technology, there are, there's evidence base for certain treatments like cognitive stimulation, reminiscence therapy, and so on. And I think increasingly we'll see technology being able to deliver that in a more efficient way, and potentially to do that at home. So I think those would be the two main points I would make.
Corinna, do you have any supplementaries on that?
No, I think it's over to Keith. Right.
Hi, thanks, and hello, Geraint. Good to see you. So I'm asking a few questions about research, and I think perhaps if we can start with what you think the sort of current gaps are, or challenges in dementia research in the area you know about that need to be addressed in terms of early diagnosis, detection, treatment, and so forth. Perhaps Zoe first, sort of the current gaps and challenges around research.
Great, thank you. Yeah, all this space of early diagnosis, I think there's a huge gap. Simply, we don't have enough data because the data we have start when people have symptoms, go to the GP, and maybe then they sign up for studies. So in that kind of early space, this 10 to 15 years before symptoms occur, we have very little data. There are studies that are now happening in the UK and in other places to collect this data. So what we need now, once this data is collected, is for this data to be released, hopefully at fast time scales, and we need to be able to put models that can make predictions early. Now, the challenge here is that we have no clinical labels and we do not have gold standards. In a way, we don't have outcomes. So what will the models be predicting? It's a huge challenge. We can build models that don't need the labels and can learn from data in, as we say, in an unsupervised way without needing labels to train on. But how do we validate? Do we have to wait for these individuals to see who might develop the disease, and will we be waiting for 10 to 15 years to see this? So huge challenges that we can overcome. For example, there are paired studies where the same batteries of tests are run on patients and on healthy individuals, and we can develop the models and validate them on the patients where we have outcomes, where we have some clinical diagnosis, and then transfer these models into the early space. There's data also that is collected in clinical practice, and it'd be wonderful for this data to be open to research. But of course, there are lots of issues here about data safety. So how do we do that? But it almost feels like a mandate if all this data of patients are there that can allow us to look at early stages when these patients were initially diagnosed, and what happened later. That would be really important. We also, there's also a lot of data there where people might end up at their GP or a hospital for other reasons, for example, falls, that could then have a sort of a clinical workup that can give us a lot of information for later dementia. So they might be healthy, but later on might develop dementia. And all of this is in electronic health records. It is within the NHS. We need to be able to pull it out and give it safely to research for the model. So it's a great time for it, because with the revolution of AI, we see a lot of potential in analyzing this data and learning from this data. At the same time, we need to be able to make that data available safely. The same thing, I think, is in the space of clinical trials. If we could imagine a repository where safely data from clinical trials could be shared, we could see why clinical trials failed. The heterogeneity of the sample that goes into the clinical trials, we know that it's a challenge, and therefore drugs might look like they're not working because people both in the placebo and in the drug group are really heterogeneous in terms of their profile. So there's a lot of work to do in safely bridging data and algorithms. The tools are becoming more and more available, but I think that's where in that early prediction and prevention space, we have a lot of work to do. And then the big piece also of wearable technology and how it can really help in a non-invasive way, because nobody in their 40s is going to want to have MRI and PET scans, but people will be happy wearing, you know, a watch and doing some cognitive apps on their phone, and combining this data with existing biomarker data could be really powerful in terms of building these reliable and robust models that then can make predictions that reduce misdiagnosis in the future.
Okay, so I think from the data point of view, I think you're saying that there's a lot there and it needs to be freed up and used for research purposes. Yeah, so a long-standing problem. Geraint will know all about that. So Geraint, what do you think the gaps are? Perhaps if you can draw on your IG experience. And I'm also thinking that the Bennett Institute and organisations like that in Oxford might actually have part of the answer here. But let's see, Geraint, what's your view?
Yeah, so I'm very much not an Alzheimer's specialist, so that you take this, you know, as a kind of public health generalist. But there's clearly a massive issue here, a growing issue. there is potential to nip the problem in the bud, as it were, and prevention is always more attractive than cure. I think breaking it down into the different types of prevention is important. So in public health, we sometimes think of it at 5 different levels. So there's what's called primordial prevention, which is the kind of socio-environmental things that could be done. So what levers do local authorities and central government have in terms of lawmaking, taxation, the built environment, and so on. So there'll be a cluster of research to do with those long-term levers. Then there's primary prevention to stop the occurrence of dementia in the first place. So what can we do to reduce the known risk factors for dementia? So diabetes, alcohol, hypertension, exercise, education, smoking, obesity. How can we target that most efficiently? Then we move on to secondary prevention, which I think is probably the most contentious, the one we've been talking about. So what would a screening program for dementia look like? What safeguards would need to be in place? How do we guard against things like the lead time bias, as it's called, and the length time bias? We talked earlier about the hazards of false positive and false negative results. So a huge amount there to unpack. And then what interventions do we offer to people who are at risk? So there's a whole spectrum there. We've talked earlier about some of the newer drugs, but equally at the other end of the spectrum, there are education packages. I know there's a big research project going on in Australia where they're offering what are called MOOCs, massive open online courses to people who are at risk to try and educate them about dementia in a targeted way. Then we move on to tertiary prevention. So for people who do have a diagnosis of dementia, what can we do to make their lives and the lives of their carers as meaningful and as happy as possible? And then finally, there's the concept of quaternary prevention, which will be dear to your heart, Keith, which is about stopping over-medicalisation. So how do we do that in the most timely and efficient way? So that, I think, is a useful framework for thinking it through. And then throughout everything I've just said, there's this lens of inequalities, which I think is critically important.
That's helpful. And do you think that sort of framework could be used to prioritise resources, prioritise where policymakers should focus?
I do think so, yes, because the temptation is that it's this sort of secondary prevention is the one that grabs all the attention, but thinking about the other 4 layers of prevention, I think, is really important because they're sometimes neglected. Yeah.
Okay.
Thanks, Keith.
Okay.
James, you wanted to come in on a specific point.
I did, thank you. It's just to pick up a point that was made earlier about the nature. You would be discussing a range of different technologies with different purposes. And there was a question earlier that wasn't quite addressed, which was around kind of commissioning and reimbursement for them. Because on the one hand, we want a personalized approach, and different technologies will be suitable for different people at different stages of disease progression. On the other hand, we're very keen to avoid inequalities and some people having access and not others. And I guess typically in this market, the early stages, you would get probably better informed people starting to adopt technology, seeing how it integrates into the way that they care for themselves and are cared for. And then hopefully over time, that then gets rolled out to be generalizable across the population. But if that gap is too long, then clearly health inequalities are going to emerge or indeed compound. And so I'm very interested to know, Zoe and Geraint, what you think about how those technologies ought to be assessed and then commissioned so that we don't fall into that trap, that kind of adoption and innovation adoption trap. So if you wouldn't mind giving a brief comment on that challenge, it would be very helpful. Thank you.
Yeah, thank you, James. Yeah, this is a really interesting and a tough challenge. I think starting from the research side of things, with this in mind, what we need to be looking is what is, if you want, the key factors that we need to be addressing for diagnosis. So sometimes it's potentially not the best technology, but technologies that give us signals that when they go into the models, they provide good information for these models. So sometimes we see that, for example, weak signals, when they're integrated with different types of information, can give the answers through the modeling. So we tend to think kind of traditionally as if you have the best, for example, MRI scanner, you will get the best result. But when we bring data from different types of data into the models can afford to make decisions from weaker signals. Now, same thing when we go to wearable tech, it doesn't have to be potentially the most expensive technology. When these signals are given to the models, they are augmented through this AI technology. And even weak signals integrated with other information can give us reliable decisions. So that's kind of the difference from looking at single modalities that maybe they're very specialized and quite expensive because of the technology behind them, compared to kind of doing things a little bit cheaper through AI. And AI has that potential in a way, as long as, of course, it's reliable and interpretable and safe. So that might be a way of decreasing this inequality, that once we have really validated these models, we could potentially be, if you want, deploying tools that are not the most expensive and maybe not the super sensitive, but because they collect different types of information that can come together through the models, this can be augmented. And in that way, it might be that we can see kind of cheaper tools that can be publicly available almost to help us collect data that then runs through really advanced models.
Thank you, Zoe. Thank you. Geraint?
So I'm genuinely not saying this just because Jill is on the call, but I really am a NICE fanboy. NICE has got an enormous wealth of expertise, and my strong point would be to kind of let the NICE process go through. So what NICE will be doing is assessing these technologies for two things. One is whether they are effective, and two, whether they are cost effective. So they'll have a standardized methodology for assessing both of those things, taking into account things like the discount rate and being able to then quantify what the cost is per quality adjusted life year. And if it meets the threshold, then it should be recommended and paid for by the NHS. And if it doesn't, then it shouldn't.
Very succinct answer. Thank you.
Thank you, James. And we come to the end of this second session. I'd just like to thank both Zoe and Geraint for their really full answers, and my colleagues for the very, very good questioning.